is Potassium Sparing Diuretics. The drugs can be classified as aldosterone receptor antagonists and inhibitors of renal epithelial sodium channels. Aldosterone receptor antagonists includes drugs such as spironolactone and eplerenone. Inhibitors of renal epithelial sodium channels are amiloride and triamterene. Spironolactone is an aldosterone receptor antagonist that acts on the late distal tubule and the collecting duct. So let's see how spironolactone acts. Aldosterone enters into the renal epithelial cell and binds to the mineralocorticoid receptor which is present in the cytoplasm of the epithelial cell. And it forms a complex that is aldosterone mineralocorticoid receptor complex. The complex then translocates into the nucleus and undergoes transcription, translation and protein synthesis. So aldosterone-induced proteins are synthesized and these are responsible for reabsorption of sodium and excretion of potassium. So aldosterone causes absorption of sodium and excretion of potassium at the distal tubule and the collecting duct. Spironolactone acts as an aldosterone receptor antagonist. So it competes with aldosterone and binds to the mineralocorticoid receptor, preventing the binding of aldosterone and the protein synthesis is inhibited. So because aldosterone-induced proteins are not synthesized, the sodium reabsorption is inhibited and potassium excretion is reduced. So spironolactone, by acting as an aldosterone receptor antagonist, inhibits the reabsorption of sodium, causing loss of sodium in urine. So it causes natriuresis, but the natriuretic effect is mild compared to loop diuretics and thiazide diuretics, which cause profound loss of sodium in urine. Spironolactone, by acting as an aldosterone receptor antagonist, reduces the reabsorption of sodium, causing excretion of sodium in urine. The action is on the late distal tubule and the collecting duct, which has limited capacity to reabsorb sodium, that is only 3 to 5% of sodium chloride is reabsorbed in the distal tubule and the collecting duct compared to the action of loop diuretics and thiazide diuretics, which causes a higher or profound excretion of sodium and water in urine. The inhibition of sodium reabsorption or natriuresis is accompanied by a reduction in potassium excretion. So there is reduced kaliuretic effect and this helps to retain the potassium in the body and it acts as a potassium sparing diuretic and helps to keep the potassium in normal range. Since potassium secretion is coupled to the secretion of H+ ions, inhibition of potassium excretion is also accompanied by inhibition of hydrogen ion excretion. Also, it is to be noted that spironolactone is the only diuretic that does not require secretion into the tubular lumen because it does not act from the luminal side. It acts at the interstitial side of the membrane. An important point to remember about spironolactone is that the mineralocorticoid receptor to which the spironolactone binds is related to the steroid receptors such as estrogen, androgen and progesterone receptors. Therefore, spironolactone, in addition to blocking the mineralocorticoid receptor, also blocks the estrogen and the androgen receptors, thereby producing anti-androgenic action. Spironolactone, because of its anti-androgenic action, can produce hormonal side effects in males such as impotence, gynecomastia and reduced libido and menstrual irregularity in females. To avoid this drawback of spironolactone, a newer aldosterone receptor antagonist is introduced, that is eplerenone. Eplerenone has more selective action on mineralocorticoid receptor and it has less affinity for the androgen receptors and the estrogen receptors. Therefore, the hormonal side effects are minimal and the action on aldosterone receptor is maximum. Some of the important pharmacokinetic features of spironolactone is that spironolactone has a slow onset of action but a long duration of action. The long duration of action of spironolactone is due to its metabolism in the liver to an active metabolite, that is candrenone, which has a half-life of 17 to 24 hours. Also, spironolactone undergoes enterohepatic circulation, and this prolongs the duration of action of spironolactone. In terms of metabolism and excretion, spironolactone undergoes metabolism in the liver to candrenone, which undergoes excretion through the kidney. Therefore, spironolactone toxicity can be enhanced both in liver disease and kidney disease. Next, coming to the clinical uses of spironolactone, which is an aldosterone receptor antagonist. Spironolactone acts as a potassium sparing diuretics. It reduces the excretion of potassium ions and helps to normalize or keep the potassium levels in the normal range. Therefore, spironolactone is combined with loop diuretics or thiazide diuretics to overcome the hypokalemic effect produced by these drugs. Secondly, spironolactone can be used in the management of essential hypertension. Since it produces mild natriuresis, it is combined with loop diuretics and thiazide diuretics so that the diuretic response is potentiated, it is enhanced, and the antihypertensive effect is augmented. Therefore, by combining spironolactone with the loop diuretics, the efficacy is increased and toxicity is reduced. Spironolactone is recommended to be used as the fourth drug in the management of resistant hypertension as per JNC 8 guidelines of hypertension. The next use of spironolactone is heart failure. An important characteristic property of spironolactone is that it increases the survival time in patients with heart failure. Because it decreases the mortality in patients, it is recommended to be used in heart failure. This action is similar to the actions of ACE inhibitors and beta blockers that reduce mortality in heart failure. Therefore, spironolactone is combined with ACE inhibitors and beta blockers in the management of congestive heart failure. The next use is hirsutism and polycystic ovary disease. Spironolactone has anti-androgenic action and causes inhibition of androgen synthesis, and thereby it is useful in the management of hirsutism and polycystic ovarian disease. Spironolactone is used in edematous conditions which is caused by altered mineralocorticoid secretion. For example, in primary hyperaldosteronism as in Cohen's syndrome, there is excessive aldosterone secretion, and spironolactone, by blocking the mineralocorticoid receptor, blocks the actions of aldosterone and is effective in the management of Cohen's syndrome. It is also highly effective in the treatment of secondary hyperaldosteronism causing edema, and this is caused in clinical situations such as congestive heart failure, nephrotic syndrome, ascites, and so on. Therefore, spironolactone is an effective drug in the management of edematous conditions caused by excessive mineralocorticoid secretion, and this occurs by the blockade of mineralocorticoid receptor, reducing the action of aldosterone. Moving on to the side effects of spironolactone, which is an aldosterone receptor antagonist and acts as a potassium sparing agent. So this causes hyperkalemia, which can be a serious side effect, particularly in elderly patients or when administered in patients with hyperkalemia or in patients who are at risk of developing hyperkalemia, such as in renal failure, patients on potassium supplementation, or drugs such as ACE inhibitors can also cause hyperkalemia. So hyperkalemia is a life-threatening side effect and may be caused by spironolactone. Secondly, spironolactone can cause hyperchloremic metabolic acidosis, and this is due to reduced H plus ion secretion, which is coupled to the excretion of potassium ions. So inhibition of potassium excretion is also accompanied by inhibition of hydrogen secretion, and this can cause hyperchloremic metabolic acidosis. Thirdly, GI side effects such as diarrhea, gastritis, peptic ulcer, gastric bleeding can occur. Therefore, spironolactone is contraindicated in peptic ulcer disease. CNS side effects are also common with spironolactone. It can cause lethargy, confusion, dizziness, and so on. One of the most important side effects of spironolactone is hormonal side effect, and this is due to anti-androgenic action and inhibition of androgen synthesis. This can cause reduced libido, gynecomastia and impotence in males and menstrual irregularities in females. Eplerenone, a newer aldosterone receptor antagonist, produces minimal hormonal side effects. This is because it has lower affinity for the androgen receptors and has more selective action on mineralocorticoid receptors. Therefore, the side effects are minimized. However, eplerenone is a substrat of cytochrome P450 enzyme. Therefore, the drugs that are inhibitors of cytochrome P450 such as erythromycin, ketoconazole, fluconazole can enhance or increase the concentration of eplerenone in the plasma, enhancing its toxicity. And also eplerenone is costlier compared to spironolactone. The next category of potassium sparing diuretics are inhibitors of renal epithelial sodium channels, and the drugs are amiloride and triamterene. To be noted that the sodium channels which are present in the renal epithelial cells are different from the sodium channels that are present in the nerve cells and the muscle. So now let's look at the mechanism of action of amiloride and triamterene. The principal cells of the late distal tubule and collecting duct express sodium channels in the luminal membrane of the epithelial cells that are responsible for entry of sodium ions down the electrochemical gradient, which is created by the sodium-potassium ATPase pump functioning at the basolateral membrane. So the electrochemical gradient drives the inward movement of sodium ions into the epithelial cells, and this is accompanied by the excretion of potassium ions into the tubular lumen. So the sodium channels allow the entry of sodium ions from the tubular lumen into the interstitium and the potassium excretion into the tubular lumen. Secondly, at the luminal membrane of the intercalated cells, there is secretion of hydrogen ions, and this is mediated by the H plus ATPase pump, which is responsible for tubular acidification. So the inward movement of sodium ion is accompanied by the outward movement of potassium and H plus ions into the tubular lumen. Also to be noted that due to the inward movement of sodium ions at the luminal membrane, there is depolarization of the luminal membrane, or the luminal membrane becomes more positive. And because the luminal membrane becomes positive, the cations or the positively charged ions are secreted in the tubular lumen, are inhibited from getting reabsorbed. So reabsorption of cations is inhibited and excretion of cations is facilitated. So the depolarization of the luminal membrane of the epithelial cell causes excretion of cations such as calcium, magnesium, potassium ions, and reabsorption of sodium ions. The inhibitors of sodium channels such as amiloride and triamterene inhibit the sodium channels that are expressed in the luminal membrane of the epithelial cells. This results in loss of sodium ions in urine, producing natriuresis. The natriuretic effect is mild. This is because the action is on the late distal tubule and the collecting duct, which has limited capacity to reabsorb sodium and chloride. Inhibition of sodium channels is accompanied by inhibition of excretion of potassium in urine. So this results in a potassium sparing action and helps to keep the potassium levels in the normal limit. In addition, potassium excretion is coupled to the secretion of H plus ions in the tubular lumen. So inhibition of potassium excretion is also accompanied by inhibition of H plus ions in the tubular lumen, thus reducing the tubular acidification. The natriuretic effect results in volume contraction, and this results in increased proximal tubular absorption of uric acid and decreased excretion of uric acid in urine. This results in hyperuricemia. So coming to the clinical uses, amiloride and triamterene act as potassium sparing diuretics. They help to preserve the potassium potassium ions and help to keep the potassium levels in the normal range when combined with loop diuretics and thiazide diuretics that have hypokalemic effect. So hypokalemic effect is overcome by the use of amiloride and trimethoprim in combination with loop diuretics or thiazide diuretics. The second use is essential hypertension. Amiloride and trimethoprim can be combined with loop diuretics and thiazide diuretics to enhance the diuretic effect and augment the antihypertensive effect. Thirdly, amiloride is the preferred drug for the treatment of cystic fibrosis. Cystic fibrosis is a disease caused by the mutation of CFTR gene that regulates the movement of sodium and chloride across the epithelial cell membranes, resulting in viscous or thick mucus secretion that plugs the respiratory passages. By inhibiting the sodium channels, amiloride is useful in the treatment of cystic fibrosis as it increases the fluidity of the respiratory secretion and improves or increases the mucociliary clearance. So this provides relief in the symptoms of cystic fibrosis. The third use is lithium-induced nephrogenic diabetes insipidus. Amiloride inhibits lithium transport in the collecting tubule cells, and this helps in the treatment of nephrogenic diabetes insipidus. The next use is Liddle's syndrome, and this disease is characterized by increased basal epithelial sodium activity. Both amiloride and trimethoprim, by inhibiting the sodium channels, decreases the sodium channel activity and is useful in the treatment of Liddle's syndrome. The next use is pseudoaldosteronism, which is the familial disorder affecting the kidney. In this condition, trimethoprim is highly effective because amiloride is excreted through the kidney. Therefore, it is avoided in kidney disease, and trimethoprim is a more effective treatment compared to amiloride in the management of pseudoaldosteronism. Speaking about the side effects of amiloride and trimethoprim, both amiloride and trimethoprim are devoid of hormonal side effects that occur with spironolactone, which is a potassium sparing diuretic. Amiloride can cause nausea, vomiting, diarrhea, headache, and it is excreted through the kidney. Therefore, it is avoided in kidney disease. Trimethoprim can cause nausea, vomiting, dizziness, muscle cramps, interstitial nephritis. As it is poorly soluble, it can cause precipitation of renal stones, and it is avoided in hepatic dysfunction as it is extensively metabolized by the liver. Comparing amiloride and trimethoprim, amiloride is 10 times more potent than trimethoprim and it is long acting. It is preferred drug for the treatment of cystic fibrosis and lithium-induced diabetes insipidus. Trimethoprim, on the other hand, is less potent than amiloride. It is extensively metabolized by the liver, therefore it is avoided in liver disease. It is the preferred drug for the treatment of pseudoaldosteronism, which affects the kidney, where amiloride cannot be used as amiloride is excreted unchanged in kidney. Trimethoprim, on the other hand, is more effective in pseudoaldosteronism.
This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.